We'll start recording and we can let folks in. So welcome everyone to this month's Federal Oral Health Action Collaborative call. Today we're talking about tools for advocacy and decision making in veteran oral health. My name is Liz Flannery. I'm an education specialist with American Institute of Dental Public Health, and I'm thrilled to be your host for today's call. So we can go ahead and go to the next slide. We'll be hearing today from Dr. Annalise Cawthorn, and our presenters are declaring that they don't have any financial arrangements or conflicts of interest. We can go on ahead to the next slide. And I will note also that Grace will be posting our housekeeping items in the chat, so please refer to those for our policies and procedures for today's call. We have 5 learning objectives for our call today. I won't go over them completely. I'll just touch upon them. You can reference our website. They're posted there fully, as will be all of our materials after this call. But for folks on this call, after participating, you'll be able to analyze the latest research reports on veteran oral health, evaluate state profiles on veteran oral health, utilize the veteran oral health data dashboard, engage in an interactive discussion session, and create actionable advocacy plans. So we can go on to the next slide. And we want to start with a brief introduction about our organizations hosting this program. CareQuest Institute for Oral Health, which supports this project, works through areas of activation and influence to bring forth ideas and solutions to create a more accessible and equitable and integrated health system for everyone. And we thank CareQuest for supporting this project. We can go on to the next slide. And American Institute of Dental Public Health, or AIDPH as we're known, our vision is an equity-oriented oral health workforce prepared to lead. Our mission is to foster professional excellence and advance innovation in the education and practice of dental health. We do this with 4 communities of focus, which are rural communities, veteran communities, which we're obviously focusing on today, LGBTQIA+ community, and people with disabilities. And we can go on to the next slide. Okay, so CareQuest and AIDPH partner to advance veteran oral health, and we do that through research, access, and advocacy. And, oh, thank you. Yes, I'll project even more. Sorry, guys. We can go to the next slide. And part of this partnership and doing this work is through VOHAC, our framework today. We do this with monthly seminars, interactive applied learning. After our didactic presentation, we'll have an interactive session. We have a certificate program for VOHAC, which you can also learn more about on our website, as well as continuing education credits. You'll receive a link for that at the end of this call. We can go on to the next slide. And More Care. This is part of CQI's framework, which underlies this program. And it is a framework that gives us opportunities for action, and Grace will be posting more information about that in the chat, a document that we invite you to take a look at to learn more and let us know if you have any questions. So we can go on to the next slide after this. And how do we do all of these pieces? We look specifically for our shared responsibility for oral systematic connection, referral network, transitioning care models, environment of improvement, and health information technology. And we can go to the next slide. So without further ado, I'm going to pass it off to Annalise Cawthorn. She's the executive director and co-founder of AIDPH, to do our didactic portion today. Thank you.
Thanks so much, Liz, and thank you everyone for being here today. As Liz mentioned, we really designed these sessions to be interactive with the intention of fostering as much dialogue with each other as much as we can, and with the experts who often join us during these sessions. So that being said, please leave comments in the chat as things occur to you. We'll leave some Q&A at the end, but we also want to make sure that we're leaving lots of room for discussion. So without further ado, I will start by just sharing, and you can go to the next slide. I'm going to start by sharing a little bit of history in case this is not familiar to you about how we got here, because it's really relevant to the topic today when we're talking about tools and resources associated with action and advocacy and application. So AIDPH and CareQuest began partnering on this specific topic on veteran oral health research in February of 2021. And at the time, there was kind of an informal discussion about, well, what do we know about veteran oral health? What's going on? And I said, you know what? I don't know. That's a great question. Despite my husband being a veteran, me being a military spouse for a very long time, being a recipient, a beneficiary of DoD healthcare. I'm a TRICARE beneficiary, and my husband being a Purple Heart recipient. So this was a very personal issue to me that I really didn't know anything about. And so in 2021, I did what I thought was the deepest dive I could manage and muster around veteran oral health. And what I found really kind of fit on one sheet of paper. So I recognized there was nothing there. And that's really a function of very few veterans being eligible for care in the VA. So there's really no one collecting this data. Veterans aren't seeing a single point of care in terms of where they're accessing dental care. And AIDPH and CareQuest sort of took it upon ourselves at that point to say, well, if there is not any data out there, then we should be the ones to help understand this issue. And that's really where it came from. It came from a place of curiosity and really wanting to understand where the outcomes are, where the needs are, and what could be actionable as a result. So throughout 2021, we partnered with veteran and active duty, some of them, it's sometimes even social media influencers, to get information. We partner with the VFW, with DAV, and like I mentioned, some active duty military influencers who could get more information, even with folks who are currently enlisted or active duty in service, to understand veteran oral health. And as a result of that, we were able to publish our first white paper in December of 2021. That was a very comprehensive look at where kind of veteran oral health, what we understood about it. And as part of that 2021 paper, we focused on what we called strategic recommendations, and a set of strategic recommendations to advance policy, to advance clinical care. And that's where we continued kind of our calls to action throughout 2022, was continuing to publish research, continuing to make inferences, and continuing to make those evidence-based strategic recommendations. That resulted earlier this year in a Hill Day. And from there, we recognized the need to continue to apply those inferences, those outcomes, and those recommendations through this initiative, the Veteran Oral Health Action Collaborative. And I bring you this history to really show you that at the impetus of all of this was understanding the research. And when there wasn't any information available, that we really took a very evidence-based and driven approach to lead us here today, which is where we're at in the application and the dissemination phase. Next slide. So these are a few of our publications, and we're not going to go in depth here today, but what I wanted to draw from here and highlight is one, our veteran oral health equity and access brief, which is on the far right of your screen. That was our paper in 2021 that we launched and really introduced our partnership, even though we had been working on it for months and months prior to that. From there, we sort of highlighted really key areas around this topic in veteran oral health. One being some subsets of veterans that we know disproportionately experience inadequate and inequitable oral health care, like rural veterans. But then we also really focused on key issues that we knew would resonate with particularly policymakers, people who are decision makers at the state and federal level, like how much does it cost to administer this kind of fragmented system of veteran oral health care? What are the particular outcomes that are exacerbating poor oral health for veterans? And in particular, where is the pain and the cost savings that we can really avert through more effective dental care? And so that's taken us to what we found to be some really important outcomes and findings as a result. Next slide. So this is my favorite graphic. And I feel like this is probably the biggest takeaway that we had through this entire relationship and through our findings. This is not magic. This is these statistics are actually released every year in the federal budget report, because every healthcare agency who provides direct services like the VA has to report how much money they're asking for, how much money was spent, how many people they saw under that care program, and pretty consistently this doesn't really change. So what you're visualizing here on the screen is kind of a representation of all 20 million veterans in the US. So the very, very light blue are veterans that are not being seen in the VA system. They could be seen in the TRICARE system. They could just be seen in private practice. They could not be seen at all. And then those kind of darker blue, not the darkest, but the darker blue represent about half of them that are currently eligible for primary care within the VA. So of the 9 million veterans that are eligible for primary care in the VA, 85% of them are not eligible for dental care. So that means when they go into the VA for their primary care appointment, maybe they're seeing their doctor for a well visit or to treat an ongoing issue, they're still walking out the door with dental pain. They're still walking out the door with unmet need because they're not eligible to get their oral health care needs met. So that tiny, tiny blue bar are the number of veterans who are eligible. Sadly, that red sliver that you see at the very end are the number of veterans who actually utilize their benefits. So even among the 15% that are eligible, only a third actually utilize that benefit. And so this is the visualization that we keep repeating because I think it bears repeating. A lot of people still don't understand that veterans just simply are not eligible for dental care through the VA, even if they're getting their other care there. Next slide. And so what we took, from those data, from those findings, we wanted to understand the potential cost savings. So knowing that veterans were walking through the doors of the VA and walking back out with unmet dental needs because of this eligibility, we wanted to understand how much money could be saved from the VA if they were able to better manage, in particular, the high-risk, high-cost veterans. So for us, we took data from Cigna Healthcare showing that true medical dental integration and managing medical issues effectively, those medical issues that are connected to oral health issues, how those could result in a cost savings whenever we went through that data and recognized that the VA, being the largest integrated healthcare system in the US, had the most opportunity to save on the medical side through more effective oral health care. Our data and our research indicated that the VA could be saving about $3.4 billion in medical costs, again, focused on those high-risk, high-cost veterans. And so what we wound up being able to do is kind of soundbite that, which is for every dollar spent on dental care, the VHA could actually save $1 in medical expenses for veterans with diabetes, and a 2-for-1. So for veterans with heart disease, $2 saved for every $1 spent. That's pretty astronomical. And again, this all started because we were really focused on how to not just understand a need, but then also launch into justifying how improved access to oral health care can not just meet the needs of these veterans who are experiencing pain, but also meet the fiscal responsibility of taxpayer dollars and wanting to make sure that veterans are experiencing a holistic and integrated healthcare approach, which is really the crux of what VOHAC was built for. Next slide. So, as part of the work that we're doing, and again, applying in a variety of ways to include VOHAC, what we have learned is that you really have to go where the data leads you. We've taken a very evidence-based approach to this, as I hope I've indicated. We've really tried to explore a wide variety of topics in the very beginning because we just didn't have any indication of what the outcomes were, truly. I mean, maybe veterans have poorer oral health than non-veterans. That was kind of a working theory or a working assumption. But at the very beginning, we took a really exploratory approach to understanding what the data were telling us. And that meant that once we had indications of where some clear disparities, were evidenced in our data analysis, that's where we decided to make our investments and moving kind of the needle forward, giving people the tools and information that they needed to make decisions, to make inferences. And then to our next point, being able to make those evidence-based recommendations. So as we were building the evidence, as we were leading with a data-centric model, then we were able to say, these are the recommendations that our data are telling us. So of course we rely on experts. Of course we rely on community members to tell us their stories, to give us context around that. But at the end of the day, the crux of all of these tools and resources has been data and what our both national surveillance systems tell us and what our survey data tell us. Point 3, as I mentioned, I'm so sorry, 2 more points and then we'll go to the next one. Point 3, as I mentioned, is partnering with the right stakeholders. So AIDPH and CareQuest have been really thoughtful in how we've approached this partnership. And that meant that we keep veterans at the center of every move that we make and every partnership that we design. I mentioned we've worked with the VFW, with DAV, with clinicians who are treating veterans, with veterans who are at the grassroots level, who are working in communities, who are rural, who are LGBTQ, who are focused on racial equity. And those are the stakeholders that we listen to add context around the data that we collect and ultimately influencing that community-based effort. So we want the data that are collected and the tools and resources that we're talking about today to be implemented for community benefit at the end of the day. And that means that the community is the center piece of everything that we do, to include decision makers at the table in terms of next steps. And to our last point, which is why we're here today, is to give decision makers the most effective resources available. So we've really had to think through what communities are available to us to work with, and what information and tools that they actually need to do their jobs in terms of implementation. How can we give them the tools and resources to go out with those evidence-based recommendations and implement them? Oh, next slide. So as part of that, giving the right tools to the right people in order to implement those decisions as a series of resources, with our intention of collecting information and getting it as granular as we can. Knowing this is very hard because so little data exists, but our hope was to give, tools at every level. One being federal, kind of national insights on veterans, which we have those publications. The next level being our state veteran oral health profiles. And again, this is data that is specific to your state, knowing that you all come from a community that we don't know as much about. State-based advocates know their states, they know their stakeholders, they know their target audiences. So you have the unique ability to actually interpret these data and implement them in a way that we never could at the national level. So here on these state profiles, you'll find information about your state, you'll find some information about each county, and coupled with these state oral health profiles, next slide, is a veteran oral health data dashboard that we've been developing, continuing to refine, and hopefully starting at the beginning of next year, we'll have a new user interface so that folks can really dive into this data, maybe in a more cohesive way. And with those two kind of resources, our hope is to give you something tangible that you can really dig into and look at within your community how chronic disease conditions may be advancing, how costs may be manifesting. And also, we are really, really interested in hearing what this means to you, which we'll get into in the second half of this session today. There's a lot that we don't know about what's happening on the state level, and there are a lot of people who are already doing great work at the state level that we'd really love to hear about. But our goal, again, was to give decision makers and stakeholders and all of those varieties the tools and resources to be able to put information into action, which is, again, kind of the crux of this Veteran Oral Health Action Collaborative. And in order to do that, we had to start with the research to get us here 2 years later, where we're able to offer more effective and granular resources. Next slide. And our intention was to sort of follow this communications process when we're talking about advocacy, when we're talking about resources, and we're talking about application. I have this discussion pretty frequently, both internal to AIDPH and with CareQuest when we're talking about our research, that research that sits on a shelf is dead. There's simply no point in engaging in research that can't be understood, that can't be utilized, and can't be put into direct action for the benefit of our oral health community or whichever community is a focus. So I wanted to offer a framework here as you're thinking through ways that you can implement these resources around veteran oral health. And I hope this is an effective framework. Whenever you're looking to apply research around advocacy and decision-making, there are a few things that you can consider. One being what we call a credible messenger, which is somebody who, depending on your message and depending on these other elements, is viewed as someone who's believable and trustworthy, and somebody that's relatable. Pairing that credible messenger with a credible message, like, well, we'll get into examples in a minute, but a credible message meaning something that makes sense to us and feels like it resonates with us. Credible, doesn't necessarily mean that it's 100% accurate. Sometimes we've seen in the media how a message can maybe resonate with us, but obviously how we're striving here is for credible, accurate messages that also align with our values and our shared beliefs. So the goal is to put those messages and messengers together into a movable target audience. And I really like to stress the word movable. Often when we're talking about advocacy, someone who is movable is somebody who has the ability to influence a decision, but also somebody who hasn't necessarily already made a decision about how they feel about a topic, or might be able to reconsider how they feel about a topic. A lot of times whenever I'm thinking through policy advocacy, I like to think about somewhere in the middle, right? So people who are on the extremes have often made a decision, or maybe they're not looking to change their minds because their decision isn't based on information. It's based on maybe political will or something at the end of the day that really is not going to be based on a message or a messenger. But focusing on who has influence and also who has the ability to listen to you and potentially move toward that message that you're trying to share. And then coupling that lastly with a feasible ask. And again, the example around veteran oral health has been, while we believe that every veteran should have comprehensive access to care in the VA healthcare system, that's not a feasible ask of policymakers at this time, because that would be billions and billions and billions of dollars. And there is no political will to move 20 million veterans into fully comprehensive care in the VA. That's not how it works. That's not a feasible ask. So a lot of our asks and a lot of our focuses, again, based on our research, has been to talk about incremental changes, to talk about the need for integrated care delivery, to talk about focusing on veterans with high risk, high cost care that has the ability to actually create a feasible incremental change into the healthcare system. So I've underscored those areas because that's where our research has really focused. who can be our messengers through our community partnerships. What can they say to people? Who can they say it to? And what should they be saying? What is the request that's being made? All of that has been underscored and facilitated through our research. And then at the end of the day, part of what we're doing right now is figuring out that message delivery system. How are we implementing and disseminating these tools and topics and research opportunities through message delivery? Next slide. So I'm just going to take one example here because I want to make sure that I'm leaving some time for questions and answers. So we're looking at what you're looking at right now is kind of our suite of information for Florida. So I have our veteran oral health state profile. If I were to look at this as a Florida advocate, I'm seeing that overall Florida was given a C on our report card. I'm seeing that, we really are not doing well in terms of rates of indenturism. I'm seeing we're really not doing well in our uninsurance rate. And when I look at Florida, I'm also seeing that compared to non-veterans in Florida, that a veteran is 132% more likely to have heart disease. So those are kind of the key aspects that I'm taking away if I'm a Florida advocate and I wanted to look into veteran oral health care for my state. Next slide. And so a way to take those tools and resources and then apply it into a framework for advocacy and action could be that I, as a stakeholder in Florida, want to find a Florida dentist who is actively working with veterans because they see the need, they're credible in terms of their expertise and stature in the community. And that what I've picked out from my state profile in terms of an important and credible message is that Florida veterans are more likely to have heart disease, which is a condition that we know affects their oral health care. And we understand that that is timely and it's important, and it's something that I can back up based in fact, right? So maybe my movable target audience is a local legislator. That may not be my member of Congress, it may not be my senator at the federal level, but at the local level, I'm understanding that I have a lot more influence. And I also know that my local legislator is pretty moderate. Maybe they engage in a lot of bipartisanship. So I feel like they are movable and they're going to look at my message as credible. And then I pair that with a feasible ask. So again, I'm not asking for every Florida veteran to be covered through Medicaid. That's not a feasible ask. But what could be a feasible ask is, let's start a pilot program, maybe with a small number of veterans through a grant program to see if we can just treat those veterans with heart disease and give them oral health care and look at the outcomes. Maybe I pair that with my message delivery system as a Hill Day. Maybe it's an individual meeting with the local legislator. Maybe the message delivery system is an email campaign or a letter writing campaign. That's really where you can be creative based on what you know at the grassroots level about what works. So we're going to skip ahead 2 slides. And I'll pause there and just ask before we go into the applied interactive learning. The intention was to kind of give you some frameworks to then go into discussion and use your state profiles and figure out how you could frame these discussions for decision making. But before we do that, let me pause and just ask for any questions or feedback.
And Rahel, would you mind stopping the screen share? We can all see while we do a quick Q&A and we can pull it back up. Thank you so much. So I know that there were some questions in the chat, but I invite you, if you're able, in a place to pop your video on and just jump in with your questions and we'll read those from the chat. So I know Teresa had a question. I don't know if Teresa, you want to pipe in.
Yeah, hi, Annalise. Yeah, I know that the data from the veteran from the VA is so hard to decipher as far as the number of veterans. So my question is, because when they always show like the number of veterans they help who are enrolled in the VA health system, right? I mean, is that I just have a question because I could never seem to get that straight. So it's like, that they are pulling the data from the veterans who are enrolled in the healthcare system and what percentage of that gets dental.
Yeah.
So then my question is always like, well, there's still a fair number of veterans who are not in the VA health system. So then that percentage of veterans having dental care is even less, right? Because if you look at total veterans. So
Yeah, absolutely.
yeah, because at one point years ago when I looked and it was like even like 8%. And then now this recent data that they published was like 15%. And so I have to reread that so many times, this like the veterans enrolled in the health system. And also I think they look at veterans who've had some kind of like a transient dental care through the VA dental because of whatever, whether it's medical condition, but some exceptional, and they count those numbers also as far as veterans who have dental care. And I think that they aren't veterans who would be able to have regular care like the 100% service connected. So so I just wanted, so finally I have somebody here that I could ask, and since you've dived into it, is that accurate to reflect on what they've reported?
Yeah, so you're right, Teresa. The bulk of care, more than 85% of veterans are receiving care outside of the VA. So, of the 20 million veterans in the US, half of them are getting primary care in the VA, but they're just not eligible through federal code. That has to be changed through Congress. They're not eligible for that dental care. And I think that's a really key component of why we have these monthly sessions and why we're so focused on action and advocacy, because the bulk of care is happening in the private system. It's happening in FQHCs, it's happening in private practice dental clinics. And that means oral health professionals here, not oral health professionals associated with the VA, actually have the most number of touch points with veterans. It also means that change at the federal level, knowing that we have to go through an entire congressional process of changing that eligibility, that changes, outside of the federal level, on the local level, on the state level. We know those opportunities are vast, and that's why we're so focused on getting these tools and resources out to people working in this field every day, because we feel like there's where the opportunity really lies, because change at the federal level happens so slowly.
Sure.
And that's why those state-based profiles and those state advocates really have the opportunity to identify changes and then go after those improvements.
Thank you.
Thanks, Teresa.
Thank you, Teresa, and thank you, Annalise. To ensure that we're able to have full time for our interactive portion, I'm going to move us into that next step. But if you have additional questions, please put them in the chat or reach out to us afterwards, and we'd be happy to address those in either of those places. So Rahel, if you don't mind pulling the slides back up, as Annalise referenced our interaction portion today, we are inviting you to use those tools that Annalise was talking about during her presentation, which Grace had put into our chat. They're actually both on the same web page. So when you click on the link, you see the state profiles up at top, and if you scroll down, you can see the dashboard down below. And we're inviting you to take a few moments, open those up, and put in your own community information to see what's there, and then discuss the questions. We can kind of advance to a couple of slides to look at the questions we have. We'll put those in the chat as well, to discuss these questions in your breakout room, which will be facilitated by a staff member. So we can pause the slides again. We can open up the breakout rooms. We'll have two rooms. Some folks will be staying here in the main room, and some folks will be going into a breakout room. So you may or may not see an invite pop up, and you can select that. And we'll give folks just a few seconds to get situated into their breakout rooms, and then we'll start discussing.
Liz, how much time will people have in the rooms?
I think we have time for at least 10 minutes, maybe a few more. we want to make sure that we have time to come back and share out. So thank you for that question, Stacey.
Okay, so maybe we'll aim to go until 50 minutes after the hour.
That's perfect.
Feel
Thank
good?
you.
Okay.
Yeah.
Okay, I think everyone is generally where they're supposed to be. So Matt, you're the facilitator for this group, and I'll be supporting you. So
Yeah.
take it away.
Thank you, Stacy. I appreciate everyone on the call, and for those of you that have your screens turned on, it's really helpful in this type of concept. Not sure if everyone had the link to what was just shared. Stacy, I'm having trouble finding the chat to drop it in there. I was just going to drop the link.
I think Grace did already. So she
Oh,
dropped
perfect.
the state profiles are in there.
Perfect. Thank you. So with
And
that being said, if you guys have had a chance to look at that, some of the things that we're wanting to know is just, with regard to your state specifically, is there anything that has surprised you from what you've seen? Or, is there anything you'd like to know more information about from the dashboards or from the material that's listed? And I'll turn that over to the group if anyone is interested in sharing their thoughts.
is anyone having trouble? Let us know if you're having trouble opening the link. When you click on the link that Grace just posted at, it says 2:38 for me, at 38 minutes after the hour, it'll take you to the page where you can then click on choose your state, where it says find my state profile.
What states are in the room? I'm from Colorado.
Washington State, just outside Seattle.
I'm in Pennsylvania.
I'm in Arkansas.
I'm in Virginia. We have no duplicates so far.
New Jersey. I feel like we're playing the memory game or something. New Jersey.
I'm in Hawaii. I'm in Texas.
That's awesome. Anyone else want to jump in with where you're from?
Maybe we could go ahead and open up. I'm happy to share my screen with one of the state profiles of someone who's on. Who'd like to do it? Who wants to be our, I don't want to say guinea pig because that doesn't really sound enticing, but who would like us to share their state? And we can all take a look at it together.
You might have to pick from the list that we said, Stacy.
How about, I'd be curious about Hawaii. Linda, would it be okay if we did that? I think it was Linda.
Yeah, I think it was Linda.
Yes, definitely. Absolutely. I wanted to say Hawaii, but I couldn't find my Zoom page.
Okay, hold on. I just opened it up and let me share my
you.
screen.
Thank you. Appreciate it.
Okay, can folks see it?
Yes.
Okay. It's been a rough Zoom day for me, technology day. So okay, so yeah, I wonder, Grace, since you're pretty familiar with the sheets,
Sure.
either Grace or Matt to walk us through what's on here.
Hey, Grace, I would defer to you. I know you
Okay,
spent more time
okay.
on this than I have.
Yeah, and Linda, is this your first time looking at your state profile?
Yes, it is.
Okay,
It
cool.
looks like
So
it's
we'll
consistent.
start at the top. So what we did with these profiles was, on the first page, try to give you this quick fact overview of about the oral health of veterans living in your state. And these are sound bites, if you will, when Annalise was sharing kind of that model of trusted messenger and message. These are intended to hopefully give you that message piece, that data piece, those facts, so that when you're speaking to the audience that you want to move, the movable audience that she talked about, you can pick from some of these facts that we've provided here in this sheet. So just from the top, we see that about 10% of the population are veterans in Hawaii. And we know that the two counties with the highest veteran population are Honolulu and Hawaii. And Stacy, if you'll scroll down, we went a little closer, drilled in a little bit to look at all veterans, working age veterans, and rural, so that you can quickly see across these 4 factors of edentialism, heart disease, diabetes, and insurance, kind of where those different groups fit. And when you scroll a little further to the dog tag, there's good news there. There weren't any rankings for rural specifically across those 4 factors, but the state rankings across the 4 conditions, this is how from worst being number 1 to best, how all veterans ranked across the 50 states and Washington, D.C. So if you look at Hawaii, that looks like pretty good news for edentialism and heart disease, right? Those are 2 of the best rankings, and actually not terrible for diabetes and uninsured. Stacy, if you wouldn't mind scrolling to page 2. Oh, well, there you go.
That we picked a good one.
I was thinking it was going to be a pretty high grade. So yeah, the magic of math. We did some weighting, and you can we've got a link there to our website where you can see how these rankings were determined, if you're that type of data person. And again, looking at each of the factors here, you can see the individual grades. So clearly edentialism and heart disease were A grades. And again, there's some talking points here that we would encourage you to use. Now, Hawaii, Linda, it's good news, but let's scroll down. We can always do better. So your message might be, yeah, we're doing well. However, looks like health insurance, we could do a little bit better in that space. So that's just a thought that comes to mind. But I open it up to the rest of the group. What else comes to mind when you see this? This ranking and this grade, and how you might use this in messaging.
This is Georgia. I actually live in Hawaii County, and I changed my enrollment in the VA to Pennsylvania because I was unable to get dental care, even though I'm eligible. They have to refer you out to a community care provider, and no one will accept the VA insurance anymore. The west side of the island, all of the providers have dropped VA insurance except for one in Kailua Kona. And they could not give me a new patient appointment for 6 months. And this was after I had already waited 6 months to see a provider up in Waimea on the northwest side. And then I got a call like a month before my appointment and was told, too bad, so sad, we no longer take VA. Okay, so I haven't been to see the dentist for over a year.
Wow.
Even though I'm eligible. So I gave up and I switched my care. I mean, if I was there still in Hawaii, my appointment was for January of 2024.
Yeah.
So, I mean, I switched my care to Pennsylvania, and granted, it's not much better. I still had to wait almost 3 months for a new patient appointment. And by this time, my broken crown, my tooth is hurting. I went in, I told them I'm in pain, and they said, too bad, so sad. Our next operative appointment is 45 days from now. See you then. So it doesn't matter what these numbers say. I mean, most people I know in Hawaii cannot act, they're getting dental care, but they're paying for it themselves. I'll tell you that
Thanks.
right now.
Yeah, thanks for sharing that story, Georgia. I saw you did that in the chat too, and I don't have an answer for you or actual site, but
I'm, you know, and here it is. I'm a dental public health specialist. I know how to access the system. So I
Yeah.
feel sorry for people who are, you know, swimming in deep water
Yep.
and they don't know what to do.
So Georgia, I think that comment's really impactful too, because this captures like claims and things that are readily available from a data perspective, but the qualitative, like your lived experience, I think is something that, you know, even as we look at this document, we don't have a whole lot of information on that component. So I almost wonder if there would be something we could do locally to capture these types of stories and feedback, right? To parallel or to pair with these dashboards, right? Because I think that's the other piece of the policy component is you have data, which if I'm a politician and I'm looking at this data, we're doing great. We have an A on our report card, right? But sounds like we might have an F in actual access or usability of services, right? So
and I'll tell you where you can collect that data is from the schedulers who work in community care in Hawaii County, or actually it's a Pacific Region VA. They have shared their frustration with me because they have people like me who get, you know, you have to request dental care. They check your eligibility, verify. They give you a referral code, and then they look up a provider and ask you where you'd like to go, which area of the island. And now they have only one provider on the west side and one, maybe two on the Hilo side that they can send people to. So I guess I could drive over to Hilo, which is 90 miles almost out of my way each way. So, and you know, it's like, I'm sorry, maybe it's 90 minutes, but it takes quite a while. And that's, you know, it's an option. But it's definitely not convenient. It is a burden. So
yeah, for sure. I like what Matt said about the lived experience piece of the data. And we did these sheets as an initial look with, the facts that we have, but what we're hearing from you, Georgia, and others is that there might be a way we can upgrade these to maybe add on the piece that next piece of the story, the next layer. So I really appreciate you sharing that because it gets my wheels turning.
I'm sorry, if there's a way you can reach out to those appointment schedulers who actually are the boots on the ground in community care, dental for Pacific Region, they can tell you how frustrated they are trying to get appointments for patients. She told me this last one when I said, look, my tooth broke finally. It's beyond hurting now. And I need some, I'm having trouble chewing. And she's like, I'm sorry, I can't help you. She said, I'm sorry, I get calls like you all the time and I cannot help you. I'm doing the best I can, but we don't have any providers to send you to.
Yeah, I totally agree with that. The Big Island or the Hawaii Island is a rural state, county, and most of the dentists are located in Honolulu. So there's hardly any dentists available on the Big Island. And that's the problem. We have problems with disabilities, the elderly, everybody, even people trying to get a regular appointment too.
Yeah, thank you, Linda and Georgia. We have now come back, all of us, and we're going to share out for the breakout room that came back in. We Our main group, we shared looking at some state profiles, and we had a few folks from Hawaii, so we were able to look at Hawaii and those numbers, and we were kind of talking about the lived experience, firsthand experience side of the data there. So for those of you who are in the breakout room, I would love to hear a share out of your discussion and what came up. And then if there was anyone in our main room breakout that would like to do some additional sharing, we would love to do that as well. And as I've said before, Grace, Stacy, and Annalise are very good at voluntelling. So if someone doesn't want to share out, you may be voluntold, or maybe Annalise can share with us.
Hey, Liz, in the main room, I was just going to share, you know, we showed the state report card for Hawaii. It had an A, but where we identified was gaps in maybe the average number of days it takes to actually get an appointment and then get seen or treated in the office. That looks like a gap we don't have in our data that might be helpful, and that, you know, a politician's going to look and say, hey, we're an A, but when it comes to access, we're probably still an F. And how do we capture that so that we can tell a more clear picture of what's actually transpiring? So that's really what we were trying to get at there.
That's great. Thank you, Matt. And to that point also, something that we haven't mentioned in this session is that you know, these tools are always evolving, and our research is community informed, and part of that is hearing back on those pieces that are most useful or pieces that are missing. We do have a Google form that we'll post in the chat if folks want to share their insights when they're looking at their state profiles. That would be incredibly helpful for us to look at the next steps that we can take, like Matt was saying. You know, just from our session just now, it's a next step of how we can improve those pieces. So that's there, and also please feel free to reach out to any of us on the call or organizations with direct comments. And I will still invite breakout room number 1 or whatever your name was, if you have any pieces you want to share back.
Liz, I'll start, and I'll say we kind of focused on that framework of messengers, messages, incremental asks as folks kind of looked through what their states meant to them. And I know there were a few people who were surprised by some of the information they found, and also found it really helpful to kind of get a granular look. In terms of feasible ask, a couple things that came up and being able to maybe move change is just focusing on prevention instead of a full comprehensive access to dental care policy piece. Just focus on the prevention efforts and really emphasizing that action piece there. And one person even shared a programmatic application. So if you're seeking fundraising, and if you're seeking ways to kind of concentrate efforts, how those state profiles can really help make the case for that and concentrate specific asks or initiatives in those areas that were outlined, especially at the county level, which I thought was a really great application that others may want to use too as a form of success.
Yeah, that's great. Thank you. Did anyone have any other thoughts they wanted to share back before we talk about next steps?
This is Waysam. I was in group 1. I didn't mention it in our bigger gathering. I just thought of it just now. But when you have data like that state profile that gives you more in detailed information regarding like concentration of veterans in what area of the state, wherever you are, you can use that to inform advocacy efforts. You can use that to help you identify which legislators, local legislators, lawmakers, policymakers that would be most interested in that. Especially you can figure out if they themselves have a veteran background and would be supportive of any efforts there.
Yeah, that's a really great point. Thank you so much. And I'll do one last invite if anyone else wants to do a final share. Okay, Rahel, would you mind calling our slides back up, and we can just give some final closeout information for next steps? We can move to the next slide. So believe it or not, it's almost Halloween. We're coming up to the end of the year. So we have one last VOHAC session and we encourage you to register for that. We hope to see you on December 7th. It is on a Thursday, but it's a little earlier in the month to avoid holiday conflicts. At the end of the session, a link will pop up. We'll also put it in the chat. There is a CEU opportunity for today's session. If you've attended the entire session, you can fill out that form and get a CEU processed for you. And there'll be a competency quiz posted in the next few days for those of you working towards the program certificate. And again, there's more information on our website about that. And you can always reach out to our program's email with any questions. So with that, I will say thank you for being with us here. It was a pleasure to have these conversations and talk to you. And thank you for all the work you're doing in your local communities. And we'll see you on December 7th. Have a great day, everyone.